This time this thing is on, so they'll actually be working. I had to re-record the last one totally after you guys did it because it was like, it was red and it was off. So when I went to listen to it, there was no sound. So I had to, that night I re-recorded the whole thing over again to put on YouTube for you guys. Like, okay, hopefully it'll work this time. All right. So I always do my little disclaimer. Everything we discuss in this presentation is of my opinion as a medical professional and does not represent the opinions and beliefs of the Esplanade. And the information is only for medical, is for educational purposes, not medical purposes. So you can't come back and say, Eric told me to do this and I had a bad reaction. So there you go. All right. So this is what we'll talk about. My first question to all of you before we get into what we're going to talk about is, how many of you would say you have quality sleep in the sense that you wake up in the morning feeling refreshed? It's a very small number. I know, Mariah, exercise.
Well, even with an 8-month-old baby.
Oh, yeah. Someone else is sleeping. That's good. And you're not actually unusual. Some people will say, well, I think I sleep well, but then the question I always ask is, do you wake up in the morning feeling refreshed? And I don't think even I do that well sometimes. So I think that's an important thing. So we're going to try to go through most of those aspects today. We'll talk about basic sleep physiology, the notion of restorative sleep, not just sleep in general, insomnia, which is common, hypersomnia, which means being very tired throughout the day, and then the condition called narcolepsy and its cousin idiopathic hypersomnolence, long-term, sleep apnea, which is common, and the other kind of cousin called upper airway resistance syndrome, or snoring with some obstructions, and then restless legs and periodic leg movements of sleep, and then maybe we'll put it all together and give some comments on that. Okay, so I think it's important to understand the basics of sleep physiology, which a lot of people don't quite know. Sleep consists of 4 successive stages: stage 1, 2, 3, 4, followed by rapid eye movement or REM sleep. This cycle repeats itself about every 90 minutes. Okay, so just remember that. REM, R-E-M, which is rapid eye movement, occurs following most, if not all, cycles, and that's going to be age and medication dependent, right? So you have 1, 2, 3, 4, then you have the REM sleep, which is where the dream state occurs in REM, okay? And what happens is that during that dream state, your brain is actually quite active. If you look at an EEG, which I used to read a lot of EEGs in neurology, you'll look, it actually looks like a very active brain. You're autonomically very active, your blood pressure is all over the place, and you're dreaming. But one thing that is happening when you're sleeping in the REM state is you're not moving. You're actually paralyzed on purpose. And that's designed to prevent us from acting out our dreams, because there is a condition called REM behavior disorder, which can be seen in some patients with Parkinson's and dementia, where they're actually literally, where they're dreaming, they're getting up, moving around, beating the walls, punching out, jumping off buildings. I mean, just crazy stuff. And there have been some court cases about murders during sleep that have occurred that thought that maybe that's a REM behavior disorder, or you just didn't like your spouse, one of the two things. So really, that's something that's real. And so we, thankfully, evolution, we've created a system so that we do not move. And many of you may have had a situation where you have like almost a sleep paralysis, where you're waking up right after, you're really tired, and you wake up after you're dreaming, and you're kind of like in this zone where you kind of like, I can't move, and then someone just touches you and you can move, right? That actually can happen for some of us, most of us at some point. But if it's very, very often, it's often pathological and can be seen as part of like a narcolepsy condition, which we'll talk about. Typically, because there's 90 minutes per whole cycle, we have 4 to 6 cycles occur per night on the average, depending on how long you sleep. So if you're doing 6 hours, is about 4, and then maybe 8 hours would be about 6, and so forth. REM stages, REM, the dream state, are longer in the later part of the night. So even though we have stage 1, 2, 3, 4, and then REM, 90 minutes, the length of each of those sections will vary as the night goes on. So REM, for example, is going to be later. You'll see, like, if you look at the app watches are very poor, but sometimes you'll see that REM gets a little bit larger as the night goes on. Whereas stage 3, 4, which is slow wave sleep, very, very restorative sleep, is actually longer in the beginning of the night. So think of the opposite of that. So the more deeper sleep, 3, 4, is more pronounced at the beginning of the night, and then it gets a little bit less subsequently, whereas REM is the opposite. But we have all of them in all stages. It just depends how much. Again, REM is associated with dreams and low muscle tone, again, a protective mechanism, and it's the dream state. If you wake up right from REM sleep, you can remember your dreams. If you did not, let's say you woke up not related to REM later on, you may not remember that dream, right? So you'll remember the most recent dream, a figment, if you're lucky, if you just woke up from it. Otherwise, you won't remember it. It doesn't get consolidated. It doesn't stick in your brain very much. Now, deep or slow wave sleep are stages 3 and 4. So 1 and 2 are very light sleep. They're not very restorative. And a lot of us, as we get older, tend to be more in lighter sleep. So we have less restorative sleep. But 3 and 4, which is like delta sleep, which is like 4 to 8 hertz per second, is going to be a very restorative. It's where most of the repair, growth hormone, DHEA, get secreted maximally during those stages. So imagine if you're not getting restorative sleep, what's going to happen to those anabolic hormones? They're going to be lower because your repair actually occurs at night in many cases. That's why you relax. Again, deep sleep stages are longer in the earlier stages of sleep. I already mentioned that. And then again, REM and slow wave sleep will progressively decrease with increasing age. So as we get older, we see that our hours of sleep is less. But what's often happening, what's concomitantly going down is not the light sleep, it's the deep and the REM, which kind of makes sense. We're not as efficient, and that's partly related to age and melatonin secretion and all that stuff. Sleep may be more restorative if we go to bed earlier and wake up earlier. So for example, sleeping from 9 to 5 is, for most people, is better than sleeping from 12 to 8. Because remember, the restorative sleep happens earlier in the night, the stage 3, 4. So let's just say you want to shift it. You'll get your sleep, but you may find that it's kind of like, not the same. I think I noticed that for me, personally. I know that if I go to bed around 10:30 to 6:30, I think I do better than if I go from 12 to 8. I feel sluggish. Something's not right. So it's, again, that finding the right circadian rhythm. And typically, the closer we are to sundown going to bed, like we go camping, when people go camping, we go to bed earlier because the lights are out. And they wake up early, and we actually go, wow, we did so much better. Part of it's being outside, but part of it also is because you're following your circadian rhythm with the lights that are actually external. When you're internally of all these sort of blue light disruptive things, it totally messes up your whole circadian biology, unless you do blue light filters. So we're always constantly messing up what our bodies want to do. And of course, that will shift things in the wrong direction. So average total sleep time, when we're 10 years old, for us it's many years ago, about 10 hours, right? And when we're 40 years old, it's about 7 hours. And 80-year-old, about 7 hours, maybe a little bit less, okay? So you can see how it shrinks as we get older, which makes sense. Now, what about REM sleep, which is dream state? When you're 10 years old, you're 30%. 30% of your sleep is REM. That brain is going, it's consolidating, it's learning, it's expanding. Neurons are going nuts. 40-year-old, about 25%, 80-year-old, about 20%, right? And many people you'll see when we do like EEGs and sleep studies, that's why I like doing sleep studies in-house, because in-house meaning in the lab, because they can put the EEG and they can actually look at your overall sleep architecture. You can't do that if you're looking to sleep apnea at home. Are you breathing or not breathing? That's all they're telling you. They're not telling you how you're sleeping in general. But as a non-REM sleep, which is that slow wave sleep we talked about, which is really important for restoration, 10-year-olds about 25%. Makes sense. They're growing. A lot of growth hormone, a lot of DHEA. 40-year-olds, 10%. 80-year-olds, 5%. So it's very small. So we're talking about, if you're talking about, 8 hours, it's probably less than an hour, And medications, for example, like if you go benzos, Klonopin, Valium, all those actually can reduce REM sleep and even non-REM sleep. Whereas certain things like melatonin probably enhances REM sleep. That's why you get a lot of funky dreams with melatonin, right? So there are medications out there that actually don't impair your quality sleep. Because the problem with meds is that they get you to sleep, but they screw up your architecture. And typically all the Valiums and the benzos will do that. But like the Lunestas and the Ambiens, and actually in the Sonatas, they actually don't mess up your architecture. So yeah, there are issues with those medications at some level, but it's not because they mess up your architecture. They actually maintain it. Trazodone is actually a nice medication that's used for old antidepressant, which is great for sleep and does not mess up your architecture and not addictive. So there are things out there, even in the pharmaceutical world, that can actually be of some value for those who have sleep disorders. So again, REM sleep, like I said, the dream state sleep is on EEG is conscious-like. When I look at EEGs and I see them like beta range, greater than 18 hertz, whatever, that's very conscious-like. But even though it's conscious-like, there's a disconnection between the brainstem and the brain, so there's not an awareness of the environment, right? It's like you're in a different world, So that you're disconnected from the external world, but you have some sort of internal activity going on. And your blood pressure, you're sweating, you're twitching, you're moving, autonomically you're very, very active. Your sympathetic system is very active, and you can see people's heart rate go up and down and go nuts, and that's normal. That's actually very characteristic of REM sleep. And that's probably how some of the apps work. They look at the ranges of your blood pressure changes. Your heart rate go up, the blood pressure changes, your respiratory rate changes. That tends to make them believe that you're awake or you're in REM sleep. Dreams are typically characterized, that you all know, by fragmented thoughts with bizarre imagery that are not stored in memory. It's almost like they're fragments of activities that your brain cannot put together. Some people will have they'll do dream evaluations where they've had repetitive dreams, and that's often you'll see that in people without trauma. They'll see repetitive dreams over and over again. That's a little bit different, but for most of us, they're just like, oh, I was just walking off a building and I fell into a cake, and then all of a sudden I did this, and it was just weird stuff. They're just fragments of memories that are just put together as the brain is just trying to consolidate information that it's learned that day. Now, there's a lot of neurochemistry associated with sleep. You may know acetylcholine from its effect on memory. Talk about dementia, acetylcholine. Well, acetylcholine secreting neurons in the brainstem will actually stimulate REM sleep and decrease muscle tone, right? So there's a lot of neurochemical changes that we have to think about that can affect whether we're not moving during sleep, or affecting our quality of sleep. So acetylcholine, think of it as important in making us paralyzed on one hand and activating REM sleep. Whereas the other things that we think about for depression, serotonin and norepinephrine or adrenaline, they're also secreting neurons in the brain stem, and they actually on purpose block REM sleep and allow for deep sleep. So it's the opposite. So things that upregulate serotonin and norepinephrine will actually inhibit REM sleep and dream state. So we have to think about when we go on antidepressant, for example, how is that going to affect our sleep? In some cases, it's not a huge issue, but for some other people, it can be really problematic. So you just got to keep that in mind. That's the bottom line there. Now, there's a lot of things that happen. What happens? What chemicals or changes can promote sleep? Because we know that there are a lot of things out there that can promote sleep and things that can make things, anti-sleep. So we think about caffeine, right? Caffeine works on a chemical called adenosine, right? And increases in adenosine, it's a chemical in the body, which progresses with time of wakefulness. In other words, you'll see that increase in adenosine will actually make you will promote sleep. Caffeine actually prevents adenosine, so it's the opposite. GABA is your sort of neurotransmitter of inhibition. So when we take Valium, it acts on GABA. Women take oral progesterone, it acts on GABA. So that's the reason why those two can actually promote sleep, because GABA is calming, relaxing. Increase in serotonin. Serotonin, it can be variable, but serotonin in the body converts to melatonin. So that's why serotonin, if you're taking serotonin specifically, not a medication affects serotonin, but if I take 5-HTP, which is an amino acid that converts to serotonin, the next step is to push into melatonin. So some people can get some sleep with 5-HTP. Inflammation. Inflammation will tend to, like when you have a flu, interleukin-1, which is an inflammatory chemical, will lead to sleepiness. It'll be more of a sleep promoting, which kind of makes sense because you're sick and your body wants to rest. So it's designed to make you more sleepy. So inflammation can do that. Certain, other hormones can do that. Opiates, of course, narcotic effects can be sedating as well. And there's a bunch of other sleep-inducing factors. So those things promote sleep. Now, what's interesting about melatonin, melatonin helps promote a more optimal circadian biology. In other words, we have a gland in the brain called the pineal gland, and that when we have light exposure, like the sun, it suppresses the melatonin from being produced and secreted. But then as the sun goes down and the blue light goes down, all of a sudden now the pineal gland can start to release the melatonin that it actually produced throughout the day, and it goes up. And that melatonin is really important for balancing the whole circadian biology, which is what we have. And if we've messed that up, then all of a sudden we're not only affecting our sleep, but we actually affect the functions and quality of cell function. So for example, metabolism, which we'll get into weight in a couple talks from now, but metabolism, stress physiology, all that changes. Antioxidants, inflammation, changes dramatically when we screw up our circadian rhythm. And the things we do every day that are probably kind of doing it. That's unfortunate. So the things that we can do to try to promote that would be helpful. Now, these are the things that kind of promote wakefulness. So if I take a stimulant, norepinephrine, right? If I take Adderall, if I take Ritalin, if I take even like Effexor, for example, those things will upregulate norepinephrine, will make me feel more awake, and I feel like I'm awake. Epinephrine is a similar one. Steroids, like prednisone, glucocorticoids. Maybe people know when they've been on prednisone before, they go, oh gosh, I'm going to go and I'm going to clean the house at 2 o'clock at night, right? You see that when people get on prednisone for a variety of conditions because it's very stimulatory to the brain. Histamine, you may have heard of antihistamines, right? Antihistamines make you sedated. Therefore, if you inject someone with histamine, assuming they don't get an allergic response, it'll wake them up. That's what happens with that. Again, acetylcholine in and of itself, as a general neurotransmitter, can make you more awake. And there's orexin and many others that are there. So there's a variety of different substances and chemicals in the body that can promote wakefulness. And some of the medications and things that we do or take can promote or inhibit those responses. Now, restorative sleep is important because that's really what matters, right? And as we get older, we tend to lose that restorative sleep. People who are very ill, have anxiety and depression, you'll see restorative sleep will drop. And if you're not restoring your sleep, then you're not restoring your body as well. So non-REM, which is stage 3-4, the slow wave sleep, seems to restore a cerebral, like brain energy stored. It's almost like it's putting gas in the brain, right? It's allowing it to sort of refill a tank when it's been empty. It seems to really promote that mitochondrial, just overall health that's happening during sleep. Non-REM sleep is also likely the phase of sleep when most of the whole body growth and repair occurs. We talked about during the day, we're doing all these things, we're burning energy, we're tearing tissue, we're doing all these things to do things. But then at night, even after exercise at night, we're repairing and restoring. That's why, for example, if you're doing a lot of exercise and you don't sleep, it's almost like you don't get the benefits of exercise. Because exercise will give you'll see bursts in testosterone and growth hormone after weight training. But you really see a lot of it during sleep, non-REM sleep. So for those people who aren't sleeping well, they feel like they can't build. They feel like, God, I just emaciated, I can't build muscle. And so are you stressed? Are you not sleeping well? Cortisol is up. Remember, cortisol breaks down tissue, right? So it's that balance. But we know that growth hormone and DHEA, which is the other hormone with cortisol, that's the yin and the yang, it's a good hormone, occur during stage 3-4. And as a result, they allow for better repair, digestion of cellular products like mitophagy, autophagy, all that cleaning house and that repair occurs during stage 3-4 sleep. Non-REM and REM sleep may also serve as a stimulus for just anabolic cerebral restoration. In other words, that non-REM and REM is where all the good stuff happens in the brain. It's where all the clean house happens in the brain, where the brain consolidates memory, functionality. So obviously we know if we don't sleep well, our brains are doing horribly. We can't remember anything, we can't function, we're tired, we have no energy. That's your brain's sort of restitution, taking your car into maintenance. That's your maintenance phase. And we think that consolidation of learning may in part take place during REM and maybe even non-REM sleep, probably REM and dream state. So that if you're not, like let's say you don't sleep well, you won't remember the things you had to run that day. You'll find that you just have a harder time holding on to things. So we think that that's where all that consolidation takes place. A lot of it does. And REM sleep may also serve to activate multiple sensory motor circuits, as a form of just cerebral exercise. Because again, it's a very active thing. It's almost like your brain is doing weight training, during sleep to try to get it stronger, better, and faster. So it's ready for the day. The brain needs to get stronger and rebuild and ready for the next day. So imagine if you don't have good REM sleep and you don't have stage 3-4, none of that's happening well. Now, what are some of the effects, clinical effects of poor sleep restoration? Now, when I say poor sleep restoration, I'm not saying, I sleep 7 hours a night. I said, okay, did you wake up in the morning refreshed? No. Therefore, you're not getting restorative sleep. You may be getting sleep. You may be in stage 1, 2, bumping into 3, 4, bumping into REM and coming right back out. But you're really not maintaining that good restorative sleep. So what happens if we're not doing that? High blood pressure, vascular disease, increase in belly fat. As a matter of fact, I've had some patients, for example, who got overweight, and they were doing the right thing during the day. They're actually doing nutrition and they're exercising and all that stuff. But one of the things I noticed, I asked them, how's your sleep? It goes, not really great. I think I may have sleep apnea. So we put them on, get them treated, put them on CPAP, and all of a sudden their weight drops. They didn't do anything different. Because now what's happening is they're reducing their cortisol, they're metabolically more normalized, their physiology is better, they're more responsive, and actually they start to lose weight. Their energy production, energy utilization is better. You see insulin resistance, pre-diabetes, so A1Cs can drop also if you do better. Poor cognition, obviously. Greater propensity to chronic illness of all sorts, right? So imagine if I'm not in good shape, I'm going to get more sick. I'm going to have more illnesses, more infections, very common, right? Like stress, same thing. Of course, you'll get daytime sleepiness and fatigue, and just a general decrease in overall well-being. You just don't feel well. And again, what are some of the things? If we test things, what do we see? We see some of the hormones. We actually see that declines in that good hormone, the adrenal, DHEA. And you can get a DHEA as a supplement. I'm not saying you should go take it right now, but I'm saying is DHEA is a very readily available supplement for people when they need it. But again, instead of just taking the hormone, find out, well, am I just lower because I'm just getting older, which happens, or am I low because I'm not sleeping well or I'm under stress? So try to understand the underlying cause of the excessive loss before just jumping on the hormone. And of course, decline in growth hormone, which happens, of course, as we age, but it's more readily happening when you have problems with poor sleep restoration. But unfortunately, the stress hormone cortisol goes up, and the appetite hormone ghrelin from your stomach goes up. And those things will stimulate appetite. That's one of the things that people notice when they don't sleep. They want to eat more. They get up at night, they eat, and so forth and so on. And just inflammation, increase in inflammatory markers can be seen as a result of just not sleeping well. The ones your cardiologist or your primary care doctor may measure is C-reactive protein called CRP. Very nonspecific. It can be any inflammation. It's like a warning sign. But if CRP is elevated, it could be in part because you have a lot of belly fat or some other condition, but it can also be because you're not sleeping well as well. And as a result, because you're getting under so much stress, your immune system is actually suppressed for fighting infections, and people who are not sleeping well or stressed, guess what? They get sick more. So you get immunological inefficiencies. So what is technically insomnia? The big question. Insomnia refers to the inability to get to sleep, which is sleep initiation, or stay asleep, which is sleep maintenance. So how many of you have sleep initiation problems? Okay. How many of you have sleep maintenance problems? Okay, fair enough. Yep, right. Technically, they're all insomnia, right? Because they affect your quality of sleep. Why do people have insomnia? Medications, obviously. Poor diet, nutrition, and the gut-brain connection. We talked about before, nutrition talk about the gut-brain connection. And that if the nutrition's bad and you're creating an abnormal microbial diversity in your gut, it can change the hormonal aspects of your gut and the inflammatory aspects of your gut, which affect the brain. We know that for a fact. So sometimes people will say, well, if I do an elimination diet, people tell me that I sleep better. Is it psychological? Maybe. But I think there's something about the food that they're eating that's less inflammatory now that's changing the communication between your microbiome, your gut, and your brain through the inflammation and the immune axis. Of course, use of stimulants, so don't use coffee or caffeinated beverages within 6 hours of going to bed. That's an obvious one. Poor health and drug habits, obviously, we all know that too. And sometimes when we drink alcohol too late, what happens is alcohol has a short half-life and it drops off, and then you feel like, oh, I get to sleep, and then I wake up in the middle of the night, right? And part of that's because you're getting a withdrawal effect. So sometimes when we have too much inconsistent alcohol use or at the wrong time, it can affect the quality of sleep as well. A lot of medical and psychiatric illnesses, for example, some people have problems with, delusional behavior or bipolar or delirium or dementia or chronic pain, especially chronic pain, really can affect restorative sleep. Anxiety, depression, stress in general. Even stress, you're not really, we have to think about it. Sometimes we just go through life thinking that stress is just normal, but our body keeps a score. whether it be just energy, whether it be brain fog, whether it be sleep, whether it be just tremulousness. Those can be the way your body is signaling that you've got something going on there. And sleep, of course, is a big one. Sleep apnea, which we're going to get to in a moment, and periodic leg movements of sleep, which we're going to get to in a moment, and hormonal changes. One of the biggest things I see in my practice a while ago was basically that when you see a woman comes in about the age of probably around, or it could be 25 even, but typically around 40 to 50, you start seeing women who come in and go, I can't sleep. I go, tell me about it. And they go that their progesterone starts to drop for the first 10 years. So premenopause is 10 years prior to menopause. So progesterone drops, and progesterone is your natural Valium. Estrogen is your natural antidepressant. So what happens is, even before there's any hot flashes from typically estrogen, women start getting itchy, bitchy, twitchy, they call it, right? They get anxious, insomnia, irritability, and the menstrual cycle is much more heavy. And the progesterone will also affect the brain. And actually postpartum depression may be related to a significant drop in progesterone. And IV progesterone can actually prevent postpartum depression in some studies. So progesterone is a really wonderful brain hormone for protection of the brain and for depression, but mostly for calming the brain. Whereas estrogen is much, much more for, we'll say, creating stability in mood. Now, women who lose estrogen as well can get insomnia because of the serotonin effect, but also because they have an effect of just the hot flashes. The regulation of temperature is big with that. So hormones make a big effect on that. And of course, shift workers, circadian sleep issues, like nurses, right? Nurses at night shifts and stuff. If they actually night shift and they go to day shift and then night shift and day shift, it's kind of horrible. As a matter of fact, they're finding that women who are night shift workers, they did a sort of an evaluation, and then night shift nurses had a higher incidence of breast cancer than those who had day shift. Makes sense. Part of it's because your circadian rhythm, and part of it's because you're not getting the melatonin. And melatonin is one of the strongest antioxidants our bodies produce. It improves glutathione levels. So there's a lot of effects of poor sleep and sleep shifting that goes on. How do you treat this? So obviously treat the underlying medical issue, no doubt on that one. If there's behavioral issues, seek out either psychiatric or even behavioral health counseling. There's a lot of things you can do with that. We'll mention a few of them. Avoid stimulants and relevant medications. Obviously, don't take caffeine within 6 hours of going to bed. And the thing is, from a behavioral perspective, use the bed, use your bedroom for sleep and sexual intimacy. Don't use it for like doing your work in bed, watching TV in bed, because you need that sort of cocoon that's for sleeping. Otherwise, psychologically, you're just thinking that it's your normal sitting space. And that's why it's good to take all electrical stuff away, all EMF, all electrical stuff away from your room as much as possible. Because some people are EMF sensitive. I mean, I would say it's kind of weird, but maybe it's psychological, maybe it's not. But there is a magnetic thing about that. And some people will notice that when they actually just move the EMF away or they change it, they actually find that they sleep better. Maybe it's a little bit over the top for some people, but I think for some people it does make a difference. So if you can try to like keep the computers out of the room, at least out of the bedroom, and maybe not put a TV in the bedroom, might be a good idea in general to do that to promote healthy sleep. And expose yourself to sunlight during the day, get your dose of nature, right? That's really important for a lot of us because a lot of us will stay inside. We're good here because we don't. We play pickleball, we go for walks, we go for hikes, we do things. But we were working, no, we're like a little like on a desk all the time. Most of us are professionals and we're not getting that. And that really makes a huge difference in our sleep quality, We went with Roy and Carol camping, right, recently, right? It was great. Not only were we sleeping, we slept pretty good, but part of it's because we were just outside a lot. And we would go to bed early, right? I think it's just that whole being outside, taking a walk, sunshine, nature, the benefits of all that are huge. So just go for a walk after dinner. It makes a huge difference. Exercise, Mariah will attest to that, and Heather as well. Don't exercise too late. Within 2 hours of sleep could be problematic, especially if it's heavy exercise. Is that what you tell people?
Yes.
Yeah, see? Yeah. So just try to do it earlier if you can because it'll stimulate cortisol and adrenaline, which will tend to keep you up. Right. and try to dim the lights earlier. Consider blue light filters if needed, blue light on your phone, blue light glasses, because blue light will suppress melatonin production from your pineal gland. And that's what computer screens do all the time, constantly. And there's a blue light filter on computer screens now, which is nice, so you can do that. But I think in general it's good to wear it because you've got the lights coming up from top that you're not able to sort of deal with. Even the LED lights, they have blue light. So try to really consider dimming earlier within an hour or two, and you might find helpful. You can get them on Amazon, but like blue light filter glasses. The ones that are yellow cut out about 75% of blue light, and the ones that are red, like red lenses, they cut out about 99% of it. And it looks like it's almost dark, but you can see through it like you get TV, and it's amazing how much of a difference it makes. Engage in calming rituals, so doing mindfulness, meditation, Calm app, there's a good Calm app you can do, delta wave sleep, relaxing music, white noise, all those things can really engage the brain to calm it down right before sleep. And really, because when you go to sleep, you should think about it, especially if you have a hard time getting to sleep, I have to do a process to allow myself to unwind from being like watching TV and watching the news and all that stuff. And all of a sudden, I'm asking myself to go to bed, to go to sleep. It's not fair. That's not a reasonable thing to do. So trying to do an hour ritual where you start to dim the lights, put the blue lights on, read a book, just take some lavender, do something like, melatonin, do some things that can kind of help calm the situation down a little bit. Some natural sleep aids that I like would be melatonin is good. Melatonin has variable effects for people. Typically 1 to 3 milligrams is a reasonable dosing range. Melatonin is not really a sedative, it's a circadian biology regulator, but it can be a little sedating for some people. Some people can wake up in the morning feeling horrible, like they feel like they're drugged with melatonin. So that's a little bit different there, so be careful with that. Oxytocin is a hormone of pregnancy. It's a hormone that is secreted for natural lactation and uterine contraction, but it's been shown that if you give nasal oxytocin, it can be great for emotional connection. Kind of like when you see a puppy, you go, oh, what a cute puppy. That's oxytocin, right? That's oxytocin. And oxytocin can really help with Asperger's. People have Asperger's. You take oxytocin, they get that connection, so you can get a nasal spray oxytocin for that. Helps with social anxiety, PTSD a little bit. It just kind of calms the system down, makes you more feeling connected and relaxed a little bit more. And some people will take oxytocin to help them with sleep too. Progesterone, especially in women, but we have given it to men, low doses, oral progesterone to help with sleep. 5-HTP is a supplement. It's an amino acid that produces serotonin and melatonin. Can be quite helpful taken at nighttime. There's great forms of GABA, L-theanine, valerian root, a whole bunch of stuff you can read. You should have the slides, but it's all there. I like magnesium. Even magnesium citrate, the one in the little container there, you can get the calm thing. But a lot of people it helps. It's calming, relaxing, helps with cramps, helps with bowel movements in the morning, and it can really help with sleep as well. CBD, good quality CBD can help with sleep. For some people, THC makes sleep worse for most people. Typically, you have to combine it. If you combine CBD, THC, you will get better sleep. But if you take THC alone, typically people get worse sleep in most cases. It's variable depending on the strain, of course. And then medications are there. They're helpful, but just resort to them only when absolutely necessary, of course. Other techniques you can use is some non-oral, non-pharmaceutical, nutraceutical ways are this microcurrent therapy called cranial electrical therapy stimulation. You can get them actually online with a prescription. Typically, you need a doctor to sign off on it. It provides microcurrent to the brain with one big electrical conduit. So it's microcurrent. It's not like TENS. TENS is millivolts or milliamps. This is microamps. It's 1/1000th. And it provides different sort of frequencies of stimulation across the earlobes. And it can actually just generate a more natural, more calming, more normalizing brain effect. So it's good for sleep, and it's good for anxiety. It may be good for depression. It may be good for pain modulation. So those are things that we've used for years, and I even have one at home, and it can be helpful. It doesn't help like right away. You got to do it for 3 weeks to notice the differences with it. Biofeedback training we talked about earlier. Just some good old biofeedback training can serve as a means to calm down the brain. Epsom salt baths. Epsom salt baths are magnesium sulfate, and they will get absorbed into the body. So they are a form of magnesium, but they help calm cramps and calm the nervous system once they get into the body. That's a good thing to do. Now, what about hypersomnia? Hypersomnia refers to excessive daytime sleepiness. It's just like not able to stay awake throughout the day. And it results from the following. Obviously, the biggest question I say, well, if you're not sleeping well, if you're sleeping too much in the day, how are you sleeping at night? You're sleeping poorly at night. So inadequate nighttime sleep or quality, frequent awakenings at night. So I get up 4 or 5 times a night, and I'm just not refreshed in the morning, from a variety of causes. And then nighttime insomnia, which we already mentioned. Sedating medications. People will take like medications for pain, for example, or anti-seizure medications, which can be very sedating, unfortunately. And then, of course, just having the condition, narcolepsy, or this other one, idiopathic hypersomnolence, which I'll mention about in a minute, that can actually be really problematic for people. So how do you treat hypersomnia? Common sense, treat the underlying medical or behavioral condition. Treat nighttime insomnia if you have it, like we talked about earlier. Adjust the diet and exercise regime, because exercise is a good stimulant, right? People actually will feel better when they exercise. They'll feel more awake and alert. And ironically, they'll sleep better at nighttime. So exercise is a really good antidote for just sleep disorders in general. Avoid excessive sedating medications throughout the day. There are some supplements that have a little bit of a stimulating property, which might be interesting. So like, there's ephedra, which is a natural form of caffeine, phenylalanine, which is an amino acid, L-tyrosine is an amino acid, of course, caffeine itself from a variety of sources like green tea would be a great choice for that. Ginseng, which is an herbal supplement, can be helpful. Rhodiola. They're all just gentle stimulants. They don't really cause a lot of really jittery, but they can be a little bit stimulating, which might be helpful to help people stay awake throughout the day. And then, of course, if it's really bad, then you go to things like Ritalin, amphetamine, modafinil, things of that nature that are more medication-based. Now, narcolepsy is kind of it's a really interesting condition. I mean, it's kind of a weird one. It's a condition where people have irresistible urges to fall asleep. I mean, irresistible in the sense of like they're just talking, like that. Literally like the computer just went off within a second, like that. And I go, what just happened? Am I that boring? What's going on? And it happens several times throughout the day in the biggest form. And it can often be associated with cataplexy. And cataplexy is a really weird condition. Cataplexy is like when you are you're talking, let's say Steve and I are talking, and we're laughing, and I'm laughing at a joke that he told me, and all of a sudden I go, and I just lose my tone. I've been like, it's a cut on my spinal cord. I lose all my tone, right? Remember I was saying REM sleep? You can't move? What's happening is your body is kind of cannot adjust. So it's kind of putting me into REM without making me sleepy. It's like getting my acetylcholine up, and it's very interesting. It's like, wow, that sucks, but it's amazing when you see it happen. And the other one that some of us have always had is we mentioned sleep paralysis, which again is like a cataplexy with sleep, right? In a way, you're kind of like you wake up and you're kind of in REM sleep, and you're sort of like, I should have inhibited my tone, but it's delayed, and I'm still kind of paralyzed when I should be going, come on, acetylcholine, go away, and then all of a sudden you kind of get touched or pushed or whatever, and you do better. That happens a lot in people with narcolepsy. It happens like all the time. And the last one is hypnagogic hallucinations. That's when you're hypnopompic, when you're either falling asleep or waking up. You're not sure if you're hallucinating or if you're actually dreaming, because you're kind of transitioning into REM or out of REM really quickly, which is abnormal, and you're just not knowing where you are. So that's sort of the tetrad of what you see with narcolepsy. And it's it's an amazing condition. I mean, people really suffer from it. But luckily, there's pretty good treatments from it. There's a lot of medications that we can use. We can do some of the similar supplements we talked about. And there's some medications you can even use to help suppress the cataplexy and so forth and so on. So there are things that we can do, and they can live a pretty normal life in most cases. But it's an amazing condition. Idiopathic hypersomnolence is sort of similar to narcolepsy in the sense of sleep. Like you just fall asleep very quickly. You can't stay awake very easily, but you don't have any of the other stuff. You don't have a cataplexy. You don't have any other stuff. You just can't. So at that point, you say, well, is it really idiopathic hypersomnolence, or is there maybe some other cause? Like I'm on medication, or I didn't sleep well at night. You go through that same litany of questions. When you look at sleep studies on people who have narcolepsy, typically it takes a while for us to get into REM sleep, right? It goes through the process. It takes like maybe 60 to 90 minutes. People jump to REM sleep pretty much, assuming they had a reasonable night's sleep the night before, they'll jump into REM sleep within 30 minutes. That's what narcoleptics do. They'll fall really quickly. They'll like just take a beeline right into REM very, very quickly because the system is so REM wired. So that's the problem with that. Whereas people with hypersomnolence don't necessarily fall right into REM. They just kind of fall asleep. So that's the way we can differentiate based on our clinical exam and EEG. So what do we do? Again, we continue. We still do frequent daytime naps. Often people with narcolepsy they get micro naps, 15 minutes, and they feel better. It helps them a little bit with just sustaining that wakefulness a little bit. Again, we talk about some of the good old serotonin medications like the thing we talk about, like Paxil and Zoloft and all the medications we use for depression, because they work on serotonin, we say that serotonin, remember, suppresses REM sleep. Well, that's not a bad thing for those people with narcolepsy. Then they start feeling a little bit better. So it can help with the cataplexy as they fall into REM quickly. They actually can prevent that from happening. And 5-HTP, the serotonin supplement, might work as well. Not great, but it might be working. It's safe to do. And idiopathic hypersomnolence is, again, similar to narcolepsy, but again, there is no REM intrusion. When you're falling asleep and you measure people, you don't see them jumping right into REM, and you don't see the other narcolepsy symptoms. So the treatment really is to increase wakefulness and not worry about the other stuff we have to deal with narcolepsy. Sleep apnea, something that's probably more common, obviously, rings home to a lot of people. It's pretty common, actually. Obstructive sleep apnea refers to the cessation of breathing while sleeping, in most cases secondary to airway obstruction from severe snoring. So during REM sleep, right, what happens is you lose your tone. So when you lose your tone, you lose your palate. And your palate falls on the top of your tongue. So you go, right? So that's what happens. So a lot of people will snore, and they might be okay. They're snoring, but they're getting airflow. They're not obstructing. They're not waking themselves up. They're waking everybody else up. They're not waking themselves up, and they may feel fine. I said, well, how do you feel in the morning? You feel like, I feel good. Okay, great. And you can measure their oxygenation, make sure they're not stopping breathing, all that stuff. Great. But if they obstruct long enough, where they're obstructing and they're trying to initiate breathing and they can't, they'll kind of all of a sudden go like that, and they'll gasp up. And if it's too long, they might drop their oxygenation below 90%. And that can put them at risk for arrhythmias and hypertension and all these other things. So in those people, it's really important to measure, to evaluate, and to treat accordingly. Central apnea is when there is a brain, like people who've had a stroke in their brainstem, can get like Undine's curse. It's horrible. It's like they call it Undine's curse. It's a curse where if they fall asleep, they stop breathing because they don't have the natural breathing capacity of the brainstem. We're not conscious, right? So we're relying on our reptilian brainstem to initiate a respiratory group to resuscitate our neurons. Well, if we don't have that, if we had a brainstem stroke, we'd have to get a stimulant. We'd have to get external pacing or some other method to stimulate our breathing, right? So it's really quite frightening, actually. Sometimes you give them stimulants; it'll help them a little bit. Where you can give like amphetamine. I know it seems counterintuitive, but it stimulates the neurons to work a little more, and they can breathe a little bit more sort of unconsciously when they're sleeping. And sleep apnea causes conscious or unconscious nighttime sleep arousal. So like some people will have sleep apnea, they'll snort and they'll change positions. And you ask them, well, did you wake up? I go, no, I don't think so. But if you look at the EEG, they were 3 and 4 or REM, now they're back to 1, back to 2. So they're not awake, but they're more awake. That makes sense. And of course, they're not getting good sleep as a result of that. So they can be sleeping all night long, but the restorative sleep is all messed up. And of course, sleep apnea will result in daytime sleepiness, headaches, irritability, and all the other stuff we talked about. It's common in people who are overweight, and they have they have like the Pickwickian, where they have a lot of tissue around their neck and their palate, so they can compress. And when they're ill, like hypothyroid, diabetes, stroke, much more prone to that. But I've seen thin people have sleep apnea too. It's not always. So don't just assume that because they're not overweight that they don't have sleep apnea. So for those who are overweight, definitely weight loss can help. Even a few pounds makes a huge difference, like 10 pounds. CPAP, but CPAP can definitely help people. Oral appliance, so a dentist can actually fabricate an oral appliance that brings your lower jaw forward, like a CPR position where they bring the tongue out. That sometimes can help in 50% of the people. But if you have TMJ, it really can aggravate your TMJ, which is unfortunate. They have a new Inspire now. It's a new FDA-approved sort of electrical device that actually is like a stimulator, and you turn it on like a pacemaker. You turn it on, and it stimulates your tongue to be pulled down while you're sleeping. So it's actually now FDA approved. So Inspire, look it up. Outside, it's all internal. You don't see it. Yeah, they wire it up. Yeah, it's weird. And it may just be like little electrodes they put in, and it's all like Wi-Fi or some sort of connection. I don't even know if it's wires. It's like, don't turn your Wi-Fi. Power goes out, you're screwed. And the thing is also too that people have if they do all that stuff and they can't get any benefit, then we will try to give them stimulants during the day we're not treating the problem. We're not able to treat the problem. We got a quality of life issue. So we'll give them like a little bit of Ritalin, modafinil, things I might use for narcolepsy. And that's the only way that insurance will cover it. They'll only cover those meds if you've exhausted all the treatments, which is kind of a drag in some ways, is because, it's like, look, I mean, they want some quality of life in the meantime. Give them some help, So while we're trying to work on this stuff, because CPAP can be hard to tolerate for a lot of people. 50% of people don't tolerate CPAP at all, no matter what you do. So, and then upper airway obstruction syndrome from snoring, where you're going like that, but you're not really having apnea. You're not really going long without breathing and dropping oxygenation. It's not as dangerous because you're not dropping your oxygen level, but it can lead to frequent arousals and everything else associated with insomnia, right? It's the same, like I'm tired, I'm gaining weight, I have no energy, I'm fatigued. Exactly. But you don't have sleep apnea, but you might benefit from CPAP, even though, because you can open up the airway and allow the snoring to stop. So they have surgery. They used to have like UPPP, where they use a uvula in the palate and take away your tonsils, and they don't do that as much anymore. I think it's a big surgery, a lot of bleeding. They do laser, maybe 50-50. ENT tends to be much more conservative on doing that right now. They would rather you do these other procedures first before doing that. And then kicking, periodic leg movements of sleep, nice term. It's when you kind of like, you're there and all of a sudden go, you kick, you're kicking your partner all night long. That often, it's called periodic leg movements of sleep, perfect name. And it does occur mostly in the lower, although it says periodic leg movements of sleep, legs, but ironically, you can also have the arms too. It's like jerking at night. It is often commonly associated, but not absolute, with restless legs. Restless legs would be like if Steve is sitting there and all of a sudden he's going, oh, I gotta get up and move. Oof, right? And they get up, I gotta walk around, they walk around, they go, feel better. Whew, thank God. If I'm in a movie more than an hour, I just cannot sit still, right? That's restless leg, like an itchy, crawly, really weird feeling, right? That's restless legs. But they're not the same thing, but they're associated. They live together. And the periodic leg movements of sleep, we'll call it PLMS, can cause conscious or unconscious nighttime sleep arousals. So like, for example, let's just say, I'm there and I kick Laurel, for example. I mean, I'll wake her up, right? But I may or may not wake up. But if you do the EEG, you might see that, like in sleep apnea, I might be pushing out of good sleep again. So what we often see is on an EEG report, we'll say, a sleep study report will say, restless leg or PLMS with or without arousals. If it's with arousals, it goes, aha, what's your arousal index? How much? If it's without arousals, it goes, hey, I'm not gonna wake it up. Who cares? As long as the other person doesn't care. And same with sleep apnea. If they're snoring without arousals or with arousals. If there's without arousals, I don't care. With arousals, we care. Now, PLMS can be genetic, family history, restless legs, family history of kicking and jerking, but it can also be associated with some conditions like the biggest one that I see, I'm always checking, is iron deficiency. Because iron is important in making dopamine. And dopamine is the chemical deficiency associated with restless legs. So if someone who's on a medication that blocks dopamine, a neuroleptic, guess what? Restless legs and Parkinsonism, right? So iron deficiency is really important. So we check for that. B12 deficiency, which can happen beyond PPI. And the thing about iron and B12 and folate, what medications can cause deficiency of all those three that a lot of us take all the time over the counter? Got too much to drink, heartburn, what do we take? Right. And 20-year-old women who have heavy menses, what are they going to get? Iron deficiency. Vegans, right? So vegan, think of like vegan, menstruating women, or people who are on medications. So just think about those things that make a difference, and they can be just one thing can be abnormal, or all of them can be abnormal, and they're all treatable, which is beautiful in that case. Neuropathy. Some people have just general neuropathy, can have restless legs from that. Any pain in general, and ironically, gut issues. So small, like SIBO. SIBO is small intestinal bacterial overgrowth. There's overgrowth of bacteria in the small intestine because of a variety of reasons. That dysbiotic, that change in gut can actually lead, for a variety of reasons, to restless legs and kicking and jerking. And then when you treat the SIBO, that goes away. Seen that? And PLMS, again, as we talked about earlier, occurs in families with or without daytime restless leg syndrome. So, again, dopamine insufficiency is thought to be involved in the pathophysiology. And if you have iron deficiency, treating it can make a huge difference because iron, again, is important for dopamine production. Treat any other underlying medical trigger. Helpful supplements include fish oil, magnesium, B12 and folate, and of course iron only if you're found to be deficient. Never take iron unless you measure. Unless you know you're like a bleeding woman or a bleeding guy or whatever. But in general, iron is very hard to get rid of in general, unless we're bleeding. So don't take iron unless you know you're deficient or you have a reason, okay? Because that's the way it is. And the helpful medications would be anything related to dopamine. So the Parkinson's medications like L-Dopa, Mirapex, Requip, whatever, gabapentin, Neurontin, clonazepam, which I don't like because it affects the quality of sleep, but it does work for that. Even a little bit of codeine can help. And low-dose naltrexone, which is something that I provide, but it's sort of an alternative medication that can help with modulate your endorphin levels. And the thing about melatonin can make restless legs worse. Key on that one, right? It helps with the REM behavior disorder. People like punching people during dreaming. It helps that, but it hurts restless legs in a lot of people. So I always ask if you're on melatonin, is it making it worse or not? Okay, take-home message. Good timing. Well, amazing. So a lot of us often underestimate the importance of sleep. We think we all do, to be honest. Same with stress, same thing. Sleep is probably pivotal in energy and functional restoration for our brain and our body. The causes of sleep disruption are innumerable and need careful attention from an experienced medical provider. Disruptive sleep is more common than we think and can have dire consequences. Improvement in sleep quality can result in better daytime functioning, as well as improvement in control of a variety of medical conditions, as we mentioned earlier. Don't take sleep for granted. Pay careful attention to it, really. I mean, because a lot of times doctors don't even ask, but just do some self-introspection. If you're not sleeping well, try to ask your partner, what am I doing during sleep? Am I snoring? Am I kicking? Am I jerking? Do I feel like I'm restless? Am I hurting? Am I stressed? I mean, take an inventory because, I will do myself. Why didn't I sleep well last night? Just try to get an inventory and then try to then go backwards and to peel back those things that are problematic if you can. And a nap during the day is not a bad thing. I mean, people talk about, well, what if I nap during the day? I think if you nap 30 minutes or less, it's good. If you nap longer, it's probably not. Anything more than an hour probably is too suppressive. It's going to affect your nighttime sleep. You might feel sluggish. A quick cat nap seems to be okay. And there's studies on that people actually do better with a little bit of cat nap. And here's the references and resources, the same as last time. This will be uploaded to the YouTube again. Hopefully there's good volume this time. It should be. It is on. Yay, green. And any other resources are all there if you want. All right? There you go. There you go.